Yeah, that's right, ladies and gentlemen. It is Health Week, and I would like to introduce my first guest to the online waves. I had a great yarn with this fella on the weekend, and I thought no better week to start off with this man. And thank you so much, Justin Edwards. I know it's a bit of a shock, like you're whacking out. You thought you had it all set up, and then I throw out a curveball and give you all these little mini squares to fit your head in. How are you, mate?
I'm very well this morning, thank you.
Oh, good. Audio's great. Internet's
Excellent.
great. It's all smooth sailing. What's news? How's your week looking? And I can see you got your polo on, ready to rock.
Yeah. I guess the week's a nice week. I'm actually off work for the week. Bit of a recharge after such a crazy year in the health industry. It was really unpredictable for us. We weren't sure as a private physio clinic whether we were going to have to move to telehealth and not be able to do any face-to-face consultations at all. So we set up for that. The clinic was quiet initially through lockdowns, and then people figured out that we were part of that medical network that you're allowed to access. So in the end, we ended up being really busy, and I think all of us at work had been heads down, bums up.
Yeah, right.
For 9 months of the year, and no one had any holidays at all. So everyone's having a little bit of a recharge now, which is nice to have the enthusiasm and the energy that you need at work each day.
I would have thought, yeah, I'm straight to the point. I'm straight away thinking about how the heck does a physio that relies on touch pivot in this particular scenario, which we're in the last year, and hopefully we're kind of worming our way out of it. But how'd you go?
Yeah, it's interesting. The physio industry has evolved massively in the last probably 10 to 15 years, especially, where by our registration, we're having to seek out evidence-based medicine and practice. And so all of the evidence that's coming out says that the exercise component of what we can offer clients and getting them moving and getting them stronger, and that empowerment of treatment that they can deliver to themselves, that education component of perhaps what's going on with their condition can help settle a whole lot of the issues that can actually lead to chronic pain type conditions. So the educational component is massive. And so a lot of the assessments you actually really can do relatively effectively through Zoom. Client expectation would have been very difficult to hit and reach and get clients to understand that the manual therapy, massage, hands-on sort of stuff is a bit of the icing on the cake, and what they do for themselves away from the physio clinic in regards to movement, strength, exercise is really what gets them their result in the end. And then ultimately that emotional support for those people through that journey so that they feel in control is hugely valuable for how our neurological system tolerates threat and tolerates possible damage, because a lot of the pain that people experience actually isn't anything to do with structural damage or anatomy actually being broken and needing to get fixed. So the more we've understood of that with MRIs and CT scans and ultrasounds and x-rays that we've evolved in the last 10 or 15 years, especially with back pain, it's almost like the more we now can look at it, the less we actually know about the structure and the tissue that's actually creating that person's pain. And so that has been a real evolution of physiotherapy, and actually does very well in a telehealth model. It's just getting that information to clients to get them to understand that the effectiveness of us involved in their care can be just as good, if not better, through a telehealth sort of consult model. So it was interesting. I was actually involved in a study through Melbourne University a few years ago where we had a cohort of osteoarthritic knees was the study, and looking at exercise based rehabilitation for OA type knees. So that typical 40 to 70 year old person that's just got a grungy, sore knee, no incident. It's gradually built up over a period of time. Sometimes they come on relatively acutely and they feel like it must be something new, but there's no incident and it's just happened for no real good reason. Usually a spike in load or something's changed in the lifestyle. In the study, what we did was actually deliver exercise advice over the phone. So no video at all.
Wow.
I would call up clients all over Australia. So I had clients in the ACT, Queensland, Tassie, and you'd go through some discussions around what their current sort of lifestyle habits were, what their exercise habits were, what sort of things were giving them problems, and ultimately prescribed, I guess, the right level of exercise-based rehabilitation for them to start with, which often is relatively simple. It's almost getting them confidence that their knee's okay, and getting them stronger, basically. And within 6 weeks, every client that I had on this phone hookup for the study were better. They were using less medication. They were describing less pain. It was quite extraordinary, quite an eye-opener as a physiotherapist, and again, helped that evolution to kind of say, actually, the massage, pushing and prodding that people kind of think and expect is a big part of their treatment, is a very small part of their treatment, and getting that compliance and consistency to doing the right things for themselves in their lifestyle. So some of the evidence says that if people lose 5% of body weight, they can get up to a 50% reduction in knee pain.
This is
so
gold.
For most people, that's very achievable. Like we do have a number of clients, well over that 100 kilo mark. And if they go to other health practitioners, often they're aware that their weight is a problem for their knee.
I'm recording
But
this.
unfortunately, they sometimes...
I'm playing this to my mum when she gets up in about half an hour. No, because it's a thing. That's a thing. I mean, I love it that you're touching on general questions that a lot of non-professionals would wonder. And we say it to people, if you lost some weight, your injury would be better. Well, here's a pro saying, okay, how much weight? Well, 5%, 50% reduction is incredible.
Yeah, and it's really achievable. Whereas a lot of those people that know they're overweight, if they look at something like a BMI, it'll tell them that they have to lose 20 to 50 kilos.
Yes.
That's a barrier to them actually getting on that journey to going in the right direction. Whereas if you've got that client that's 100 kilos and you say, right, if you can achieve within the next 3 to 6 months a 5% reduction in weight, then you can get up to 50% reduction in your knee pain. That's powerful, and that's achievable. They can lose 5 kilos in 3 to 6 months.
How many people in your experience, and I know this is a hard stat to just grab right now, but percentage of people that do actually take that 5%, they finish it, do they snowball on?
Yeah, absolutely. Because ultimately you give them the tools to be able to start to achieve that journey.
Yeah.
So for most clients in Australia that I see, they're pretty good with what food they need to have going in. They've always got a couple of things that you can kind of go, okay, pick out that one thing that you have that is clearly not the best choice that you're having, and maybe the one that you're having slightly more often, and kind of go, okay, let's just work on that one thing.
Wow.
Don't try and do a whole fad diet sort of thing. So you sort of attack little parts within there. And they don't necessarily need to start with a dietitian at that stage to have that really structured professional input to that. They can sort of start that journey and be on the road to going in the right direction before they really need maybe that nitty gritty of the specifics that might really make it even more effective to get that significant weight gain. So you give them that education around some of the food stuff. And like I say, most of the time it's relatively simple. Pull out maybe one thing that you kind of go, yep, that's my choice that I know it's not a great one. Whether it's soft drink, whether it's ice cream, whether it's alcohol, it's fairly straightforward for most people. They know there's something they kind of go, that's the one thing I can easily change. And then you start them on some really simple exercise sort of stuff and hit some exercise goals. And in that NEOA study, it was about 10 minutes of exercise 3 times a week. And simple stuff like step ups and sit to stand. That sound really simple, but for lots of these clients that are coming from a low exercise base, it's a great place to start. They're safe. They're happy to start with that sort of stuff. They don't need to buy any equipment for it, and it starts them on that journey. And once they see the success, then their buy-in's massive, and they go and seek out more thorough personal trainer, dietitian to really kind of go, wow, hold on, I started with 5% and now I can see that it's achievable. I can lose maybe up to that 20, 30, 40 kilos that certainly some of those people will massively benefit from, not just for their knee, but obviously that's where, as a physio, there is a component of lifestyle diseases like diabetes, heart disease, stroke that we know are linked to weight. So that's where
That's huge. That's huge.
Yeah, it's really interesting. That's where I guess as a physio, clients aren't necessarily seeking you out for that, but as a physio, we're trained, and it's really important that we're looking after the whole person rather than just their sore knee. And so there's a lot of education that we have going on in the background when we're assessing someone that certainly is hopefully a bit like a duck on water, where we look pretty calm, and sometimes some of the stuff that we deliver can be fairly simple. But underneath, we're going through a whole lot of analysis and understanding of what's going to benefit that person as a whole person rather than just their sore knee that they think that we're there to help them for.
Big question here. Where does the physio stop and the myotherapist start, or the osteo start? You're a physio. You seem to be, and most physios probably been around for a long time. Keep fresh by finding out some other alternative, and the information's out there, and it's crazy. You can really open up your education. But where does a physio stop, or
it's got almost more and more complicated, open, both for us as practitioners and I think as the general public, of who do I seek out? I don't know who's the right person to see, and unfortunately that again becomes a barrier to seeing anyone, and they sit at home kind of going, I'm sore, I'm having problems, but I'm not sure. Who do I trust with this information, and who's the right person? So it is really complicated to navigate through the healthcare system.
Yeah, because you get conflicting,
to a certain degree.
You get conflicting information.
Yeah, absolutely.
All the time. I know my mum's journey has been, someone said massage it, someone said don't massage it. Like just a simple thing like that. So she massaged the problem. She's been in more pain ever. Went to another person that goes, no, don't touch it. She's paying money for the other guy and not for this other guy.
Yeah, look, it is. It's really tricky, and I guess to me, I try and be an open-minded practitioner, whereas there's certainly a whole lot of practitioners that kind of go, I'm so confident in my own little world that I'm the best person for everyone to see, and I guess I'm realistic. And the good thing about our clinic at Corio Sports Med Centre is that we've got a great cross-sectional area of all different disciplines within the building. So we're continuing to learn off one another and inter-refer when we get stumped by a patient that we feel like we've done the thing that should benefit them, and they just aren't reporting the changes that you expect. So I guess as a physio, again, we try and have assessment criteria and asterisk signs, as we call them, that help us prove that what we've done interventionally with that client is actually making a difference to that thing that they wanted to make a difference from. So that accountability, both to ourselves and it's fairly transparent to the client that we're changing something that we are measuring and showing that that's relevant to their condition. And if we can get that to stay better on our objective test, then we expect that their pain will follow. It doesn't always marry up straight away, but we're trying to certainly stay analytical of our own success and demonstrate that to a client. So as a physio, we're bound by some of those structures within this evidence-based medicine. And so staying up to date is challenging when you're trying to be at work and treat patients. And I guess as one of the senior clinicians there, I'm generally booked out up towards 2 weeks in advance. So I could open up my books and just treat more patients, but it's hard to then stay on top of seeking out more evidence, discussing with other clinicians in the clinic. Like we've got some really well-credentialed Chinese medicine doctors in our clinic that do a lot of acupuncture, but they do a lot of other health stuff. So Dr. Zhen Zhen's a qualified medical doctor when she goes back to China, and in Australia, some people kind of go, oh, I'll see Zhen for acupuncture. And you're like, the knowledge that she has as a practitioner, and it's really tricky because trying to marry up Eastern medicine, Western medicine together is complicated. And ultimately, through the journey, Chinese medicine hasn't had this strong push to be much more science-based. But Zhen is very much trying to marry that up and actually understands the landscape of healthcare in Australia, that we need that accountability to our interventions with clients. And so trying to do studies and actually demonstrate what she knows as a clinician from her experience to actually kind of say, well, these are the clients that really works well for it, and trying to stay analytical. So it is tricky. I think as a physio, because of that evidence-based background and because of our understanding within that medical pathway of being part of that client's journey rather than having to kind of go it's tricky balancing for some of the small clinics, especially. My business needs to have patients to pay money to survive as a business. If I refer this patient on to another clinic, then they're not necessarily benefiting. So there's a tipping point where you get, I guess, to a certain degree, either, unfortunately within all professions, there's great professionals that just do the right thing by the client. And whether that's a mechanic or a landscaper or whoever, that they'll just do the right thing and kind of go, oh, this is not my thing, but I know this other guy that does this really, really well. He builds pools and I build retaining walls. But you're both landscapers. So I guess as a physio, we're lucky in our clinic where even within our clinic, we can onward refer to the right people, but we're also busy enough that in the end, we just want good results for our clients. And so if it means referring to a practitioner outside of our clinic group, there's no problem doing that, whatever is best for the client. And that's I guess to a certain degree, the luxury that we have. And like I say, that base of other disciplines around Geelong, like Geelong's really blessed. The geographical distance to get to different places is, it's crazy how easy and accessible it is to get to that right practitioner. So as a physio, very much part of our job, because we're primary care practitioners, where someone can walk in off the street without a referral through that medical network, but they're getting screening from a clinician that we're looking for things that you don't know we're looking for. Like some of the questions we're asking, we're screening for things like cancer. We're screening for things like heart disease. We're screening for things like deep vein thrombosis in a calf. So, I've had 2 in my clinical journey where they've walked in with just, I've got a sore calf. Can you just massage it for me? And you go through your history and you're checking with this because both of these clients stood out. One was an obvious, she was going to be a DVT, where ultimately she'd had a knock to her calf or an incident overseas, and then sat on a plane, sat in an airport, and then sat in another plane to get back to Australia, like maybe 15 to 20 hours of travel. And she knew she had a sore calf getting off the plane the first time. She came to me with this sore calf a couple of days later. And it's sort of classic sort of stuff that she didn't really have the strain tear sort of thing. And ultimately went and got an ultrasound scan. She had a deep vein thrombosis. With that in Australia, we manage that with medications that thin your blood so that we don't get a clot going somewhere else. So for that lady, there's a possibility if we massage her calf and we move that clot goes to her heart, her lungs, or her brain. And she has a pulmonary embolus where the oxygen transfer can't get through her lungs. She has a heart attack or she has a stroke.
Wow.
So, that's the thing that it's a scary world to a certain degree as a physio, because you're screening and looking for these things, and because people can walk off the street with things that are not necessarily straightforward. It's that mismatch of pain and severity of damage are often poles apart.
The body's so unpredictable at the moment. Hearing you speak, it's real fragile and unpredictable, and it can go
it's
any
a
old
really
way.
tricky thing that we're screening.
Any old way.
And yet the reality is that we don't see those things very often. But so I've been a practitioner since 2001. I've had, I think, 2 or 3 DVTs.
Right.
I've had probably 2 people that had a tumour cancer type presentation, one benign and was kind of okay. But one was a more significant, nasty one. And at Corio Bay, we had one of our younger physios, which was an amazing pickup. He had a young kid with a sore leg, and he treated it for, I reckon, 2 sessions and kind of went, this doesn't make sense. Went and got some information, got some scans, and he had quite a nasty malignant tumour in his leg. And the pathology got sent off to America, and they said it was the earliest diagnosis they'd ever seen. Like, they struggled to diagnose it in America because they'd never seen that picked up so early. So, by looking for that stuff and being aware that it's possible, you go searching for it. And that's where you need clinicians that are engaged with not just treating what presents to them, but checking and monitoring for some of these other things that are possibly there. So it's a tricky thing as a physio. There's a lot of responsibility that I think a lot of clients don't necessarily understand, that's kind of part of our responsibility in our journey.
I've got some questions here, Justin. So it's great to see that people are really taking this opportunity to have a chat with you. This one's from Jano. Do you see many young people with posture-related problems? Any little tips? This is Jane's a teacher, by the way, so probably is really concerned for kids as well, and especially habits. Any little tips for helping kids avoid or correct bad posture?
Yeah, it's an interesting world, the posture sort of debate. Again, it's one of those things that has evolved and changed massively over the last 10 or 15 years as we do more and more studies looking at, okay, let's get 100 people with bad posture into a study and try and look at, does that create damage and structural change? Does that actually link to their pain? It's almost got a muddier outlook than before. So we're less specific to saying there's a good posture to be in, that you have to have this ideal, perfect posture. So one of the best, I think, ways to describe that these days is that your best posture is your next posture. We've shown that as a human body, we're better to keep changing positions and precisely
it's making me
different positions in different places, and your body actually will often tolerate that. So the typical thing that we would see in a teenager of poor posture isn't necessarily the biggest problem that they're ever going to have. We need to actually be quite specific to assess that and check whether it's actually a problem. And ultimately, a lot of those kids, as they go through their adolescent growth years and get bigger and stronger and more skeletally and muscularly mature, actually won't necessarily have any pain or disability associated with what was perceived as poor posture as a kid. So we're not that concerned about it as we used to be as a global sort of thing. And yet, in the last couple of years, I've had a couple of kids referred to me with really fairly significant scoliosis. So that's that sideways curvature through their spine. And when you look at their scapula, one sort of up and, how do I get this?
I remember getting
up and forwards and rotated this way, and one sort of sitting a bit skew-if over here. And you look at it and you kind of go, that doesn't look great. And they've been monitored by pediatricians to check whether they need to do significant invasive surgery where they put two big metal rods all the way up through their thoracic spine. Like you're talking 15 to 20 centimetre rods either side of their spine to make them straighter.
Right.
You've got to have a fairly significant curvature to even get close to deciding on that. And so as a practitioner, you see heaps of people go, I've got a scoliosis, that's my problem. You're like, it's so subtle, you can hardly sort of figure it out. And you go, that's not creating your pain in most presentations. But these couple of kids that came in, I looked at them and we looked at sort of some of the things that I've, one of the best things I did was took some serial photos of this. It was about a 17 or 18-year-old kid with lots of headache kind of activity. And so we took a group of serial photos of what was his comfortable posture, where did he want to sit? And then I'd say to him, okay, now sit in what you perceive as good posture. And then I'd ask him to sit in the most extreme good posture that he could get to. And so I took those 3 photos over about a 12-month period of time. And we worked on not his scoliosis, which for 5 years his doctors had told him was his problem, but we worked on getting him taller and being able to pull his chin back. So if I sit side on, so, oh God, I've got to go back here.
Yeah, you go back, that's it.
So he was that really poked chin.
Yes.
And we got him to be, much taller and understood this movement of retraction. So protraction and retraction is the stuff that people generally don't understand. And again, that comes back to my McKenzie-based training so Robin McKenzie's a New Zealand physio who looks at spinal stuff really, really differently. And so that retraction movement, that pulling back movement is one that most people aren't necessarily super aware of. And ultimately, Robin McKenzie looked at sort of postural sort of stuff, and he ultimately sort of showed that the neck goes down to about T7 functionally. And so the middle of your chest for a lady, pretty much where your bra strap goes across, that he would say that's your neck all the way down to where your bra strap is. And so this upper retraction movement happens in that upper thoracic spine, as well as the lower cervical spine, which is probably what we perceive as the neck, and often how we're sort of anatomically trained in Australia is that our neck goes down to the cervical vertebra, which is just the top of your neck up here.
Yes, yeah,
Whereas
yeah.
Robin says it goes down all the way to your bra strap level, pretty much reciprocally nipple level.
What is that, an extra 2 knuckles or something? How many further on than?
Seven.
Far
Seven vertebrae below our perceived neck. And so
7?
that retraction happens there. So we worked on that with that young kid, and ultimately his headaches totally resolved.
Wow.
Like no headaches whatsoever. Wow. And he's kind of a digital media kind of guy. So he does a lot of head down activity still. And yet now has no headaches.
Wow.
And I haven't changed his scoliosis at all.
Wow.
We have changed his posture and his strength. And it wasn't just his headaches that changed. His confidence as a person was totally different. He was a real introvert and a really quiet kid. And then, I think he wasn't confident from a body image point of view, because aesthetically, when you were in that posture, and when people for 10 years of your adolescent life have said, that's going to hurt you, that's bad, that looks ugly, that person feels bad about themselves, and they hide even more. And to see him grow as an individual now, it's really cool.
It's the best. I've got another question. Thanks, Jez. Has Justin done much study with back pain and CBD THC oil? He's had a herniated disc, S1L5, and pain for 7 to 8 years. Been on a clinical trial with CBD spray, I think that was meant to say, for 12 months. And on a personal note, have seen a 60 to 70% reduction in pain, which has allowed me to move and be more active.
Yeah, it's a new world. It's certainly not my area that, I guess, again, it's going to sound bad to a certain degree, had time to go and explore really aggressively. It's very much the chronic pain world has kept searching for the magic bullet, because we haven't found the answers in a massive way. When I came out as a physiotherapist in the 2000s, graduated as a physiotherapist rather than come out. I've got 4 children, so I was told that we had to teach people, and we used to use ultrasounds to look at transversus abdominis and multifidus, these 2 relatively small muscles, one deep in the abdominal wall and one small and deep in the lower back, that we were told that teaching people to activate and turn these muscles on would change their pain. And it just didn't happen. As a young junior clinician, I was trying to go, if I try and make those muscles work individually, I find it really difficult. And I've spent time doing anatomy. We do full cadaver dissection as physiotherapists to really look inside the body and understand it. And I'm finding that difficult, and I've got no pain. And we've been told that people with pain have a reduction in activity in these muscle groups in particular. And yet, so therefore it's hard to switch them on, supposedly, when you've got pain. And I can't do it when I'm pain-free. How the hell am I going to get a patient to do it?
Yeah, exactly.
So we did that for about 10 years, and then it was pretty much in the evidence showing that it really didn't help. So ultimately, we've moved away from a lot of that feeling of you need to consciously activate target specific muscles. And actually what we've shown is that pretty much just getting people moving and getting them confident in their body movement, that if we look at MRI diagnostics on a lumbar spine, if we screen the general population, there's heaps of people with diagnosable lumbar spine disc herniations and what reads on a report really, really bad, and they're walking around pain-free and never had any pain whatsoever. So we know that the anatomy doesn't link to the experience of pain all the time. There's probably 80 to 90% of people where you can't actually kind of end up saying that structure is definitely creating that person's pain. As a physio, we ask questions about people's distribution of pain and intensity, and we look for spinal reflex kind of stuff, so your knee reflex and your Achilles reflex, and distribution of paresthesia, so changed sensation and feelings of pins and needles and stuff like that through different areas that would help us understand that's possibly coming from a nerve root that may link to that person's scan, but a lot of the time it doesn't. So that's where, CBD oil and these types of modalities that interact with the neurological system, I still think is going to be where we can help these people more to change their pain experience that allows them to get moving and get more active. And we know that in the end, the evidence shows that if we get those people moving and more strong and confident in their body capacity, that it has tolerance, that it is the spine is so robust and actually designed so well even to tolerate having disc herniation sort of stuff, that a lot of people can very much live a better, more functional life. And if we can get them focusing on what they can do and what movement and activity they're capable of doing, they can grasp back aspects of their life that we know are a really poor predictor of someone's outcome. So, return to work times and all that sort of stuff post injury. So whether it was a true structural change or whether there was a threat to that person's neurological system and their fight or flight response has gone into almost an excessive sensitivity. And so they experience excess amounts of pain related to the severity of the damage kind of stuff. And the neurological system really is the part that, if we can understand that and interact with that on a better way, that hopefully is going to be where we can make better gains in the next 10 to 20 years of healthcare. So certainly it's a tricky one, because any intervention, we have to look at the safety of it. And that's where I think there's this layer that clients kind of go, there's obviously a lot of people out there that use marijuana as for a whole lot of different reasons, and they can fall into this trap of saying, oh, look, I get pain relief from it, but for us as health practitioners, the side effects and the evidence we have around that, we clearly can't kind of say the risk reward of that.
Little pause here, ladies and gentlemen. Hopefully we'll be back online in just a second. We are speaking with Justin Edwards, physio, absolute guru, and someone who absolutely loves his job. It is a beautiful thing. He'll be back in a second. Oh, no, he won't. We just dropped out here for a second, ladies and gentlemen. Hey, thanks for the questions too. I think what this segment has shown. Hang on. We're here. Sorry, we had a little drop out. Where are you? Give me a sec. I know exactly where we lost you, so I'm going to pick it up right there. Sorry, Justin.
Yeah, all right.
My internet company's going to get a little call at some stage today. There we go. We're back.
Hello.
Yeah, we're here. You talked about risk and reward.
Yeah, so
that's where we lost you.
We have to, as health practitioners, protect clients from that safety aspect of things, and that's where ultimately the evidence base and the thoroughness with that to make sure that ultimately any intervention that we have has low risk of a negative effect. And unfortunately, that's kind of the reality with just about everything. I mean, like lots of safe medications that if you read the possible complications or contraindications around it, there's a lot of people that clearly get spooked by it. But the disclosure of that is really important because it's a possibility. It's clearly gone through a stringent amount of analysis to check that is infrequent. And the trickiest thing is that as much as we try and say that this person is very similar to this other person and we can predict what's going to happen in one person's body, the chemical reactions that happen in different bodies that unfortunately at times are unpredictable, it's a tricky world to be in. So as a physiotherapist, our mantra is, number one, do no harm to the client. Number two, especially when we're thinking about manual therapy and within the clinic, is do no harm to us. And number three, is actually try and do something positive and helpful for that person's presentation. So again, that's that little bit of a duck on water, hopefully, to clients that we're considering all of that stuff before we actually do anything to try and be helpful for that person. So that's where the CBD oil needs, clear analysis and thorough monitoring from an appropriate practitioner. So that's not me at the moment. That's obviously pharmacy, medical, doctor, practitioner kind of stuff, and a lot of the chronic pain clinics to make sure that those things are really done thoroughly to protect someone from that.
If you just tuned in, and sorry about that little glitch in the stream before, but we're back. It's just a little 15-second glitch, but we are speaking with, and yeah, Jano, great, such good advice. Don't stop moving. We're speaking with physio Justin Edwards, who's down at Corio Bay. Is it called Corio Bay Medicine? I
Sports
see it.
Medicine Centre on Latrobe Terrace.
I've seen it a billion times going down the highway going, what a weird spot for a medicine place, but it's right near the football ground.
Yeah, I mean, like the clinic historically was built on Geelong Footy Club. So
was it?
Yeah, years and years ago. All the footy players would wander into the main clinic and get treated alongside the general public. It was a pretty
cool,
interesting, and certainly, lots of clients kind of enjoyed that. But certainly, obviously, as the AFL's become more and more professional, they hire their own staff full time. But certainly, still a link of the clinic to Geelong Footy Club, and certainly George Atkins, one of our physios who's come through over the last few years. He ended up with one of the full time jobs with the AFL Cats last year, and was up in the hub through the year. So got his mug on TV plenty of times. So yeah, still a good link to the footy club, and through obviously my experience with Geelong Falcons now being so strong down there, there's still a link to a whole lot of players that have come through Geelong Falcons in my time that are down at the footy club, that you stay in contact with plenty of them, and always good to see them around the traps.
I think there's some great things to come from this, and good reminders, and I think it's an industry, the health industry, when you're undiagnosed, is go get diagnosed, but some things you just don't know what to do. But I think lose some weight if you've got knee or back or injuries might be, or look at what you're eating, and remove one item that is a bad one. And clearly sugar or booze. I mean, people always have great benefits from no booze for however long.
Absolutely.
Even a week or so, but to keep moving. But hey, I feel like, and I've got to keep moving and play some more tunes before our next guest comes on at 8:30. I think this needs to be Ask Justin segment most weeks. It's ridiculous. Your information is, and I'm sure you're like the local mechanic for your mates. Go, hey, Jazz, what should I do here?
Yeah, it's
so valuable, man. So valuable to get locked in information about things that's super important. It's your health.
Yeah, you've only got one body and you got to look after it.
Got to look after it. Hey, mate, I appreciate you coming on and kicking off Health Week, man. It's been a pleasure talking to you, and I hope you have a great week, and thanks for your time.
My pleasure. Thanks very much, Troy.
You're a ledge.
Cheers.